Hello and welcome, Andrea Brockberg from Minnesota Women's Care. I am beyond honored and grateful to have you be part of this World Menopause Day Summit. The Minnesota Women's Care has been and continues to be an instrumental part of my own journey, and I'm so deeply grateful for your support. And after an 8-year long and quite unsupported years through perimenopause, I'm just so thankful that I found your office. And now that in just a bit over 6 months, I've gone from feeling like I was on the brink of extinction to returning to the vibrant and thriving person that I felt like I've always been. So I just really want to thank you.
Well, thank you for having me. It's a pleasure to be here, and I'm glad you're feeling better.
Yeah, well,
Like
thank
yourself.
you. Yeah, so today we're going to discuss the hot topic that is typically called HRT, also known as MHT, menopausal hormone therapy. Its history, the pros, the cons, who it's for, and who isn't a candidate for it. So let's just start with a bit of history and context. Can you talk a little bit about the WHI, the infamous WHI study?
Yeah.
Why so many people believe that estrogen causes cancer.
hmm Yeah, the WHI Women's Health Initiative study, I remember the day that it came out in 2002. I was at work and all of a sudden the phone started ringing with women who were on Prempro or all hormone therapy actually in a panic and stopping their medicine. And what do we do? But basically, what happened that day was that the study came out and it said hormone replacement therapy increases the risk of breast cancer. Other things too, but the big hook was the breast cancer. Um, they also said that maybe they saw an increased risk of clots, strokes, heart attacks, other things, but people got really hooked on the fact that it increased the risk for breast cancer. And then when the media got a hold of it, they were saying there's a 20% increased risk for breast cancer if you take hormone replacement therapy. So that was scary. But what it came down to was that it was women who were 55 and older using the hormone therapy for longer than 5 years. That's where the risk appeared to happen. And what they found was, so a typical risk of breast cancer is going to be around 30 women out of 10,000. And the women in this study, it was 38 women out of 10,000 had breast cancer. So there were 8 more women out of 10,000 that had breast cancer who used hormone replacement therapy. Well, what they didn't do is sort of boil it down to see that there might be differences in the type of hormones that are used. And so then a few years went by and they started to look at things a little bit more. And what they realized was it wasn't necessarily, these women were on an oral combination synthetic pill. So some estrogen with some synthetic progestin. And it was that pill that increased the risk. When they extrapolated it down further, it wasn't the women that were on an estrogen only pill. It was the women that were on this combo pill with the synthetic progestin.
So there
So,
was
um,
one pill, so there was progestin and synthetic estrogen or estradiol in one pill.
in one pill.
Okay.
And it wasn't even estradiol in there. It was conjugated equine estrogen. So the
Oh, the horse
hormones that
pee.
came from the horse
Okay.
pee, the horse pee
Okay.
pill.
Thank you for
So
clarifying.
and so they let the women on just the horse pee estrogen keep going because they didn't really have these significant risks, but they made the women on the combo pill stop. So from there was a big scare. I mean, and that was what, 21 years ago or something. And so finally, with the passage of time, researchers started looking and digging a little deeper, and they realized that it really didn't, for that big risk, that statistically significant risk of 8 more people out of the 10,000 didn't really apply to women on estrogen alone or other forms of estrogen. So it really became that the culprit was that synthetic progestin that was in that combo pill, and it was oral. That was the other big difference too.
Yeah.
So, and that's not to say either that that form of estrogen is fine and the best one yet. There's that one, which I'll just say CEE because it's so long to say conjugated equine estrogens, but estradiol, which is generally more plant-based or comes from yam, is the better one. That's the safest, cleanest one, which is the ideal one that you would want to choose.
And that's the one that people are using more often, called that people refer to as bioidentical hormones, which is
Correct.
different than like the Premarin and the that of the 80s.
Yep. Yeah, Premarin would be the brand name of that CEE form of that estrogen in that original study.
And no criticism. I mean, I've no doubt that the people who were doing this study had the best of intentions. I mean, they did a lot of gathering information. That's the thing about science, right? Things we learn more and we move on and we get more information. And but I heard another physician say that that study and that sort of twisting of those statistics, was like, and this is certainly an opinion, but the one of the largest debacles in modern medicine for the last 2 decades, and how many women have been underserved. And just because of that, just baby out with the bathwater, right?
Yeah, yeah, completely. Because then, fast forward fortunately, over the last 10 years, there's been, kind of a reintroduction and more acceptance of hormones and more studies that are showing like, okay, if you're using this kind over here, the risks aren't there. So there's been a slow, gradual acceptance again of menopause hormone therapy, but there are still providers that were, trained or, just coming into practice at that point in 2002. And you kind of get stuck in what you learned at the time. So, yeah.
Right.
Mhm.
Yeah, and I've also found that in my studies that like typically most OBGYNs I've heard have maybe 2 hours or so of, there's very little, I'm sure that's must be changing, but
Mhm.
previously it really has just sort of been like the blind leading the blind for quite some time. So
Yeah.
I'm grateful that things are changing. And so let's talk a little bit about no, so now we're fast forward, that's neither here nor there. Here we
Yeah.
are. We have new options, we have new information. What are the risks and what are the benefits of MHT?
Yeah. So, some of the risks are, the breast cancer is the big thing, right? So what we know is if we forget about the old one and just think about the more bioidentical hormones that should be the ones that we're using now, the breast cancer risk only increases to one more person per 1,000 in bioidentical hormones. And then you can even look at extrapolating that even further, because that might be someone's genetics, predisposition. It might be the way they metabolize their sex steroid hormones. There's lots of variables in that. So that's the big thing is, and it really, with breast cancer, it kind of comes down to how many years it's used and what are the risk factors in that individual woman. There's other things to think about for risk with breast cancer, or excuse me, with using hormones, but that's kind of the big one. Another risk is endometrial cancer, but that really kind of goes away if you're given your hormones appropriately, which is if you have a uterus and take estrogen, you must take a progesterone with it to protect the uterus.
Yeah.
Yeah. Yeah.
Yeah, it's interesting that, and this is just my own observation, that, having been of the generation that now has, had birth control through, I mean, many women that I know have been on hormones and birth control, they're, to varying degrees for different reasons, their entire adult life. So
Mm-hmm.
it's interesting that and I will say even had my own judgment about HRT or MHT because I thought it wasn't natural and it was another way of the overculture trying to get in the way of women aging naturally. And until I started getting my butt kicked from all of these incredible symptoms that no amount of nutrition or was really impacting. So I
Mm-hmm.
just think of this, it's sort of interesting that having through 20s 30s heard like taking birth control pills increase the risk of breast cancer.
Mhm.
Well, I don't know anybody who hasn't, gobbled up their birth control pills and not even thought anything about it. But
Right.
when it comes to, you know, hormones in for menopause, that's like,
It-
oh,
Right.
do you know what I'm saying?
Yeah, and birth control pills are synthetic, and usually the doses of birth control pills are higher than the amount that you use that you need to manage symptoms in menopause. So it doesn't exactly
There's
make sense.
I'm just acknowledging a little irony and my own knowledge and learning as well. So just pointing that out there. So
Yeah.
let's talk a little bit about, and I know this is so subjective, and there is so much about I think medicine that wants to put particularly women into just sort of a box, right? Of like all things for all people. But we know that every woman's journey is unique, and every woman's journey is valid, and you have to sort of find what it works for each individual person. And so, that said, who is a good candidate for MHT and who is not?
Yeah, so that's a great question. So, ideally, the good candidates are going to be women who have menopausal symptoms. We don't have to do hormones. There's so many benefits to it. But if you don't have big risk factors for things we can talk about in a little bit, and you feel great, you don't have to do hormones. But in general, I mean, the best candidates are going to be women with the menopausal symptoms, the hot flashes, the night sweats, the mood changes, vaginal dryness, just not feeling like yourself, not having the endurance, you're exercising and you don't see your muscle mass building, all of those things. Women who are at low risk for breast cancer, and then women who are at increased risk for osteoporosis and cardiovascular disease, cognitive decline, dementia, those sorts of things, and even type 2 diabetes. So those are going to be the best candidates to think about doing hormone replacement therapy.
Yeah, awesome.
Mhm.
No, and so as I've shared, my journey really only began after I had a wrist fracture while ice skating. Then that revealed an osteopenia diagnosis, which is the early stages of osteoporosis through a DEXA scan. So can you talk a little bit more? You just sort of touched on it there, but how hormones support just our bodies function beyond just reproduction, and why they decrease when and women are at greater risk for heart disease and bone fractures like me.
Yeah, so I can talk kind of about the bone health piece of it since you had a personal experience with that. But one of the things that happens is as we lose estrogen and start to deplete, that impacts our normal bone turnover cycle. So it means that we can experience more bone loss and less bone growth. And so that's how we start to see changes in our bone density scans, and an increased chance to see osteopenia, which are the early signs of loss, and then osteoporosis, which are the later signs of loss, which are really correlated with a higher risk of bone fracture. We see the biggest change, there's sort of a slope. And so the first 5 years of menopause is when we see that biggest dip in bone mineral density. And then it keeps going, but it slows down. It doesn't take such a rapid pace, but those first 5 years, that's the most significant change. So that's another reason why there's this concept called the timing hypothesis, where if you're debating about using HRT, the timing hypothesis kind of says that you're better off starting it kind of early in menopause, first 5 years, or for sure the first 10 years, if you're hoping to get certain benefits from things like, bone health and cardiovascular health, because you're trying to get in and supplement the estrogen before the body has had extended period of time without it and gone through some of those changes.
Can I
But
pause here and ask a question?
yeah.
Say earlier, you're also meaning like in perimenopause, roughly, it or versus like what is, because I've sort of read different things that like there's great
Mhm.
benefits of women, starting in perimenopause in their early to mid 40s leading up to. I've also heard
Mhm.
lots of people who are like, my, doctor will not even consider giving me hormones. So any way to
Yeah,
traverse
that's a
that?
good question too. Yeah, so typically those big significant changes are going to happen in those first 5 years of menopause, meaning that point where you've had your last period, which you really don't know because it's a retrospective thing. It's 12 months, since the last period, you're technically in menopause.
Let me tell you, I got there to like 9 or 10 months. It's like, oh, I got to start over again. It's like, yeah.
Yes, you do. The clock
Yeah.
starts again. Yeah.
Yep.
Sad but true.
Yeah.
But so most of the time, if you're with the decision and utilization of hormones, it- we can start estrogen in the perimenopause phase if the lab work and the symptoms suggest that that would be a good fit. Oftentimes in the perimenopausal phase, we're looking at a couple of other hormones, maybe as the primary needs at that time. One of them is progesterone, and for some women, testosterone is the other one. And then, we sort of individualize the needs for estrogen at that stage because we just don't know what the ovary is going to do. Sometimes we have a period and then months go by and we don't. And what we don't want to do is be giving sort of a menopausal dose of estrogen in the perimenopause when we don't know that those ovaries might kick in and start offering up some estrogen again. And then you can, mostly mood wise, sometimes symptom wise, can just feel estrogen dominant. And we try to avoid that if we can.
Yeah, and I would imagine, I mean, there and again is just like more testimony of the importance of finding a good clinician that is informed in this, more modern medicine, because many women may often, are in their 40s are still taking birth control pills or other, maybe they have an IUD, which has, progesterone sometimes, so
Mhm.
yeah, I mean, just again, everybody is different and finding the good, the right clinician to have these, just good conversations and make sure you're getting what's right for you. So,
Yeah, really important. Yeah.
so oh, sorry, go ahead.
Oh, did you want me to speak at all about the cardiovascular
Yes, please,
piece
please.
too? Yeah. And so part of that WHI study was like it made us really scared of hormones for cardiovascular risk because it increased the risk of blood clots and heart attacks and all of this stuff. But again, it really had to do with that combo oral based method of taking your hormones. But estrogen protects our cardiovascular system in a lot of different ways. Estradiol, there's different types of estrogen, but I'll speak specifically to estradiol. That's the most common bioidentical form that we see. There's some formulations and creams that have estriol too, but we'll speak mostly about estradiol because that's kind of the most common, best one that makes the biggest difference for us. But in general, estradiol can reduce overall inflammation in our bodies, specifically to the cardiovascular system. And we like to keep that part of our body calm and not inflamed, because when it becomes inflamed, that's when things like increased cholesterol and atherosclerosis and conditions like that can start to happen. One of the other things that estradiol can do is it reduces oxidative stress. They're sort of these particles that can get into our vessels and contribute to increased inflammation and be a factor in, worsening cardiovascular issues. And so estradiol can kind of work as a cleanup crew to kind of reduce those as well. And so when that happens, we see a reduction in atherosclerosis. They have a vasodilation property, which means it helps keep our vessels more open and flexible versus closing up and getting tighter. If our vessels are closed and tight, there's a higher blood pressure because we have to work harder to get our blood through our veins and arteries. And it also can work on the cardiac muscle. So, sometimes a lot of women will feel like they're getting heart palpitations and things like that. And sometimes it's because of the, hot flashes and all that stuff going on, but there might be a component to that drastic shift in the drop of estrogen. So the other thing that it can do, so that's all cardiovascular stuff, but estradiol can also improve something called insulin resistance, which puts us at increased risk for developing type 2 diabetes. So, there's so many benefits. But again, it really comes down to that timing hypothesis, not letting too many years go by without it, so that because we're not going to necessarily undo things that happen, but we want to kind of jump in before these things happen, more of it as a preventative step.
Yeah, and again, this is very generalized, but I've read that it's sort of around like at that 60, if you've how many is there a general rule of how many years? If you
Mhm.
have been in menopause, haven't had a period for a year, how many years if you how many years can it go before you can or they say that you should not? Does it make sense? Like
Yeah, I hear what you said. Exactly.
yeah.
Yeah. So there's sort of a 10-year rule, kind of, is it black and white? No. But in general, sort of that getting started on it within 10 years is when you're going to have the most benefit and the least risk. And then kind of the other part of it is sort of like by the age of 60. If you're kind of getting up to 60 and beyond, you're not necessarily going to have the same benefits as you would if you had started it sooner.
Right. Thank you.
Yeah.
And I think that that was another piece of the, not to go backwards, but another thing of the WHI study is that some of those people in the same cohort were of, in their 70s who had not, or, in their mid to, 60s to 70s who had not been receiving any hormones and then suddenly, were receiving the hormones. So the
Yes.
cohorts were very like not, I mean, a 75-year-old woman and a 45-year-old woman are apples to
Yeah.
avocados, right?
Yes.
So, yeah.
Right.
Yeah.
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 Yeah. Yeah. That study, you had to be at least 55 and using the hormones at least for 5 years. Yeah. So it was, yeah, you're right.
Well, it's interesting, and thank you for sharing that information about estrogen. I think that, because it's thought of as like a sex hormone and it's just for, women and that, it's just reproductive. But I was amazed to find that there are receptors all throughout our entire body, including in our brains, uh,
Yeah.
of for estrogen. And so it's not just not getting your period and getting sweaty, which I sort of
Yeah.
thought, menopause was, it affects so many aspects. And like you said, many people can transition and then their bodies metabolize and they're just fine. Some
Hmm.
people, like myself, are a little more clunky in their journeys and, can use some help. So
Yeah, absolutely.
so and speaking of that, the two most obvious symptoms are the vasomotor symptoms, the hot flashes or the night sweats. But there are over 50 symptoms that can affect someone peri to postmenopause. And many women don't recognize that depression, anxiety, feelings of rage, and even suicide. Like I think 45 to 55 is the highest rate of suicide in women. That's an interesting time frame.
It is. Yeah.
So what a coincidence. So that those feelings that they can experience that and not actually realize that it's menopause. So is MHT something that can help with this as well as the physical symptoms?
Yeah, for sure. In fact, sometimes that is the predominant symptom that some women have. Anxiety for sure is a huge concern. We hear about someone may have never had anxiety in her whole life, and then all of a sudden she's anxious and doesn't know why. And yeah, we have estrogen receptors in our brain. We have other, sex steroid receptors in our brain. And when we start to deplete or have irregularities in our secretions of those hormones, it can be a trigger, and the brain just kind of is like, what is happening here? And so, yeah, those hormones all can offer us really strong, like neuroprotective benefits. So for, mental fog, clear thinking, moods, depression, anxiety. And they're even really looking now at cognitive decline and dementia and in that whole area too.
Yeah.
So yeah, there's good data that is showing that HRT can improve mood and depression, preventing the cognitive decline. There's a SWAN study in 2017 that they found that a decline in estrogen may be one of the major factors in the development of cognitive decline, specifically related to just aging. So
Yeah. Yeah.
yeah.
And just in case there are viewers who don't know what cognitive decline is, what is
Oh,
cognitive
yeah.
decline?
So cognitive decline is just sort of losing that. I mean, in the earliest forms or the simplest forms, the most common ones are just sort of like you're forgetful, you can't remember things, you don't feel as smart, you try to do a meeting and you stumble on your words, you can't think of that, your memory is really bad. But then, later on progressing, it can be as significant as dementia or Alzheimer's.
Yeah. Yeah.
And, we're thinking that a lot of that has to do with that the sex steroids are anti-inflammatory. They keep everything calm. And then when you pull those away, the system becomes more inflammatory. And that includes our neurological system.
Yeah, awesome.
Yeah.
Thank you for clarifying. So, well,
Yeah.
as we're sort of wrapping up here, do you have any final words of wisdom to share?
Yeah, I think this has been great. It's just, my words of wisdom are just that HRT can just offer tremendous benefits, to our health and, addressing some potential chronic issues that develop. Osteoporosis and cardiovascular diseases and hip fractures are things that are real and significant and can really be modifiable if we implement hormones at the right time. But even if we're just looking for symptom improvement, it can really enhance our quality of life going through this stage. It's oftentimes the first time in someone's life that they don't feel good or they don't feel who they are, and they want to get that back but didn't know that there's a way to do that. So we spend a third of our lives in menopause. That's a really long time. So now that we're kind of we've swung back, and it's suggested that bioidentical, what, maybe these hormones are okay and they might have a big benefit for us. I'm glad that we've come back to this again. So I think the other thing is the decision has to be individualized, and you want to sit down with your provider and you want to, make sure they're aware of your full personal health history and your family. And you just choose a method that's going to be most effective for you and the safest for you. And hormones aren't a one size fit all. It's not one pill or one dose of a patch, or you have to find the method and the fit and the dose that's right for you, that keeps you feeling the best. So don't give up if the first try doesn't work. Just keep at it, and eventually just find the combination that helps you the most.
Yeah, thank you. That's so important. It was my neighbor actually that referred me to you. And when I asked her what is it like? And she said, well, I just feel like myself. And
Yeah.
I'm like 20 something, like I'm not trying to achieve something that I'm not, just feeling like myself. And that's definitely like just stepping into it. Now I understand what she's saying. It's not
Yeah.
for everybody, but I'm with you. I really feel like take what works, leave the rest. Women
Yeah.
deserve the right to have the conversation and just figure out what works for them.
Yeah,
So,
absolutely.
yeah, well, thank you, Andrea and Minnesota Women's Care, for sharing your knowledge and resources today. You can find out more about them or schedule an appointment if you're in Minnesota at mnwcare.com. And I just am so grateful for you. And thanks for
Well,
joining
thank you. Thanks for having me. It's been a pleasure. Thanks, Laura.